like to thank all of you for joining us this morning. We've been hearing a lot about CARES in the news, and I thought, who better to hear from than someone at the fire department, So I've been working with Bernadette Galvez, and I said, Bernadette, can you set us up? And she did. That afternoon, Assistant Chief Stedman got in contact with me, and we were able to schedule this. I'm really happy that he's here to talk with us about CARES. As the presentation goes along, feel free to unmute yourselves and ask questions. Jay, I'll let you take it over from here.
Thanks, Mike. Yeah, I pretty much do whatever Bernadette tells me. So I'm happy to be here with all of you all today. Just real quick background. My name's Jay Stedman, and I'm the Assistant Chief of Medical Affairs for the Fire Department. So anything that has to do with the medical side of the fire department responses is my responsibility. And in late in 2020, we had an alder from the city of Madison approach us about doing something different for our mental health responses. And she brought some ideas from programs around the country that were running very successfully. And that was kind of the genesis of how the program started here, was basically just by, a good city council member that said we need to do something different. And luckily, we've had a lot of support. And this is in my opinion, after working on the fire department for 28 years, this is probably the best example of intergovernmental and also working with private agencies, like all cooperating together, that I've actually ever experienced. This has been a really positive experience, not just for the police department, the fire department, public health, Dane County Human Services, Journey Mental Health, but most importantly, we think we're having a good effect on the citizens that we encounter out there that are having behavioral health emergencies. So I've got 23 slides that I'm going to show you. Like Mike mentioned, please just ask questions as you have them. I for sure won't talk at you for an hour. My presentation itself will probably only take about 20 minutes, but I hope we can lengthen it with some good questions, and I'll do my best to answer everything I can for you. So I'm going to go ahead and share my screen and get the presentation up for you. Okay. And Mike, just to confirm, you can see that okay?
Yeah, can do.
Okay.
It's great.
Wonderful. So our program that's called CARES, it's a long acronym. It stands for Community Alternative Response Emergency Services. And just to kind of get into why we did it, I mentioned, that an alder brought this program, the genesis of it started with just one single alder that was concerned about how mental health calls were being handled in our area. But, when we started looking around the country, we recognized that, the need is certainly there for us, right? The last few years have increased behavioral health crisis, such as suicides, drug overdoses. There's a lot of risk factors around these behavioral health crises that have been exacerbated by the pandemic, right? So job loss, depression, social isolation, serious illnesses, substance use disorders, barriers to healthcare. All that stuff existed before, but the pandemic certainly made those risk factors a lot more salient. So, given this rising trend over the last few years, we definitely saw an opportunity to do something different. So, as you know, historically in the city of Madison, like a lot of other cities, the behavioral health response was very law enforcement driven. And, I'll tell you that the Madison Police Department has done the best they can dealing with behavioral health emergencies over the years. They've got mental health officers. They get extra training around behavioral health emergencies. But, just the fact that a police officer walks into a room with a weapon on their hip and, they look very authoritarian, that can be escalating for folks. And so, what we found was best practice around the country was to send, unarmed responders that were trained in behavioral health emergencies to calls like this. So, so what is CARES? We're a team with one paramedic from the fire department and one crisis worker from Journey Mental Health. And just to be clear about why we have the relationship with Journey, it actually goes back to the state of Wisconsin Department of Health Services. So DHS actually has an administrative code that gives every county in the state of Wisconsin the statutory authority to oversee mobile crisis response teams. And Dane County Human Services has a contract with Journey Mental Health. So by the language from the state, and with that County Human Services contract with Journey, that's why we work directly with Journey Mental Health. And so if the county ever changes who they contract services with, that's who we would work with, because all of this is overseen by the county by essentially DHS 34, which is the code that drives all of this. So if you're interested in all the paperwork and all the stuff that guides us, you can Google DHS 34 and read through that huge long document that basically outlined how we ran our program. So behavioral health emergencies, like I mentioned, are anything from suicidal thoughts, depression, anxiety, agitation, confusion, isolation. We actually go on check welfare calls as well. If you get a phone call saying that basically, hey, I haven't seen my grandma in 3 days. I haven't been able to get a hold of her, and I live in Minneapolis. Can you please go check on her? That's something that the CARES team can do as well. So it's not just active behavioral health emergencies, but we'll also do check welfare calls on folks that haven't had any contact with their family or friends. So who responds when CARES is called? Like I mentioned, it's that paramedic from the fire department and a Journey crisis worker. Right now, there's 2 teams running between 8 a.m. and 8 p.m. Monday through Friday. When we first started this program in September 1st of 2021, we only had 1 team that was running from 11 a.m. to 7 p.m. Monday through Friday. That was kind of our pilot program to make sure that we were kind of, we started slowly so that we could evaluate what we were doing and make sure it was best practice. And over the time, as we've gotten more funding, we've been able to extend into the 2 teams. And our next expansion is going to be weekend hours. So by the end of the first quarter of this year, we will be able to cover weekend hours from 8 a.m. to 8 p.m. as well. So it's important for us to be able to provide the service 7 days a week. And then ultimately what we hope to do is be able to provide the service 24 hours a day, 7 days a week. We're just trying to be very thoughtful about how we expand, and obviously there's budgets involved and a number of other things, but we'll get there. We've had a lot of support around this team, and they've been successful, so we expect to keep expanding as we can. So how do I request CARES has been a common question, and we're only a 911 service right now, so there is no landline, there's no 1-800 number. This team was funded to be a 911 service. And so anybody that calls 911 right now in the city of Madison and they complain about a behavioral health emergency, whether it's themselves or somebody else, and it's nonviolent in nature, the 911 center dispatches CARES by themselves. If there is any mention of a weapon or violent behavior, the police department still gets sent on that call to make sure that they make the scene safe. But then they can bring CARES in to handle the de-escalation further, and then of course do the on-scene interventions and treatment. And for us, most importantly, it's the ability to be able to refer people to the right services in the community. In the past, the police department, their only option was really to take somebody to the emergency room or possibly to jail or possibly to detox, but they really didn't have the ability to transport people to, a residential center in the city or a treatment center or a homeless shelter. They were kind of limited in what they could do, obviously. So the CARES team now is able to not only visit people in place of law enforcement, but they have a lot more options as far as what they can do with people. So I already kind of mentioned when CARES is available, Monday through Friday, 8 a.m. to 8 p.m. And what types of services does CARES connect patients to? I'm gonna show you more about that, but just a short list right now. We use peer recovery coaches. We can connect them with case management services. The Aging and Disability Resource Center is a big one. Recovery rehab centers, shelters, detox facilities, psychiatric facilities, counseling services. So we've opened up our 911 services to a lot more referrals that are more appropriate for people. And basically, here's our goal, right? Our goal is to reduce our patient contact with police, diverting them from jails and from emergency rooms. And most importantly, is to provide patients with help specific to their needs. It's about the right intervention at the right time as early as possible. So there doesn't, during a 911 situation, they should get the help that they need right away rather than seeing a police officer or possibly an ambulance or a fire truck that really can't address their issues appropriately. So the fact that a crisis worker can walk through the door as the first responder really does make the service more appropriate for the people receiving it. And then, like I mentioned, connecting patients with all these additional support services in the community is really the end goal. So I mentioned, journey crisis worker and MFD community paramedic. And I think it's important real quick for me just to kind of describe the difference between a community paramedic and what we call kind of a standard 911 paramedic. So the Madison Fire Department has, 380 employees. About 100 of them are paramedics, and every firefighter that works on a fire truck is an EMT, and our paramedics work on our ambulances. But they're not trained specifically around how to deal with mental health calls and behavioral health emergencies. They get some training, as everybody else does, but they don't get specific training around behavioral health emergencies. And so our community paramedics, we have a small group of people that train specifically to go out into the community and work with people and refer them to services. So it's more of a social work position in the fire department. And traditionally, community paramedics would help people that had chronic health conditions that were low acuity, but people would call 911 all the time for them. And we would see these really high utilizers of 911 services when they really needed kind of healthcare system education, right? 911 isn't the best answer all the time. So our community paramedics would go out into the community and talk with people about, using the healthcare system appropriately, making sure that they were visiting their primary care doctors, making sure that we looked at their medications so that there was medication reconciliation and that they were doing everything right. So now that we're kind of working in this crisis arena, we also get special training around crisis response. So for instance, one of the courses that our community paramedics took was the NAMI 40-hour crisis intervention training. They did a training out of UW Green Bay that was like a 17-hour training on de-escalation and crisis response. And so, not only is there a trained crisis worker from Journey Mental Health, but the paramedic, the community paramedic that is there also has that de-escalation and crisis intervention training as well. So we all, they're 911 responders, so they carry radios so that they can communicate if they need help at any point. They can call the 911 center to ask for backup. And right now they're working 10-hour shifts. And the other thing is that when we first started, we were only responding in the downtown area of Madison, so the Isthmus in the downtown area, because that's where we saw the highest need. But we've since been able to respond citywide. So anywhere in the city of Madison that there's a behavioral health emergency, care should be able to respond between the hours of 8 a.m. and 8 p.m. And so dispositions, this basically means, what the team is able to do for people as far as taking them somewhere and resolving their issues. They have the autonomy to determine where is appropriate for somebody. And the reason that's important is because our 911 ambulances that work for the fire department, we have 9 of them. The only place that they can transport people is to an emergency room. And that's by our operational plan with the state. We can't take somebody to an urgent care, or we can't take somebody to a detox facility. We can't give them a ride home if that's where their support network is. And so CARES, because we're not charging for this service, and we're using, a fire department SUV, we can take people wherever it is that they need to go within reason, right? We can't drive them to Chicago, but if they need to go somewhere in the county because that's where their support service is, we can do that for them, which means that we're not utilizing hospitals for just a drop-off point for everybody that's having a behavioral health emergency. And a lot of the calls end up with us just providing support on site. We don't end up needing to transport everyone, just simply de-escalating people, giving them some on-scene interventions, referring them to a service is a lot of times enough for someone. but when people need it, we can take them where we need to take them, connect them with services, and provide a warm handoff. That's a big benefit for this CARES team as well, is that they're not just taking somebody somewhere and dropping them off. They walk into the facility, they explain what's going on, and they stay there with the patient until there's an appropriate transition of care. All right, I'm going to take a pause real quick just to make sure that there's no questions, because I drank a lot of coffee, so I'm talking really fast.
Hey, I wanted to ask here, let me chime in.
Yeah.
Are you able to hire the quality of staff that you need? How long does it take to train a community paramedic?
Yeah, great question. So we hire people that are already paramedics. So we wouldn't hire somebody and then train them as a paramedic. So we hire people that are already paramedics. They have to have at least 3 years experience. And then it takes us a couple of months to train them for crisis response specifically. So I mentioned that NAMI 40-hour course. They do training with Journey Mental Health. They sit in the crisis unit and listen to calls and kind of get a feel for the types of emergencies that come into the 911 center. And so it takes us, if we did it as quick as possible, it would take us about 2 months to train the paramedics to be crisis paramedics. But the key is the journey crisis workers, right? So these are people that either have master's degrees in social work with a crisis specialty, or they have a bachelor's degree with a certain amount of years of experience. So the journey crisis workers are already expected to have all of that training already when we work with them. But yeah, we've been fortunate in hiring these community paramedics that we've been able to find folks that are dedicated to this type of work. One of our paramedics is bilingual Spanish speaker, and he worked for the State Department previously and has a lot of experience around mental health responses. And we've been fortunate that when we've hired these community paramedics for this work, they've stayed with us. Now, I'll tell you that, in crisis work in general, so whether it's journey crisis or a lot of other social services out there, as I'm sure you all know, they don't pay great and it's stressful work. So there has been some turnover with the journey crisis workers, but luckily that they've got, enough employees to keep the team running. But it's unfortunate in my mind that, these folks, these social service providers out there, from social workers on down, just don't seem to be getting paid a whole lot for very stressful work.
What would be the typical starting pay for someone who's, what do you offer people when they're, when you're trying to recruit people?
Yeah, so our community paramedics are not firefighters, so they're not our commissioned firefighting staff. So they start out at about $65,000 a year, and that's with good city benefits and everything else. So that's what the paramedics are making, and the journey crisis workers are just a little bit more than that, like somewhere like just a little bit less than 70. I think it's 82,000 a year, and that's salaries and benefits for the journey crisis workers.
Okay. We have a couple of questions in the chat box here. Karen asks, can you tie into the new 988 hotline?
Yeah, great question. So 988 has a central call center. It's near Green Bay. And what that central call center does is triages that 988 call to the appropriate 911 center at the appropriate county level. So we do get 988 calls, but they come through the 911 center, and then the 911 center here in Dane County triages them to the right response. So if the 988 call, for instance, comes in as somebody trying to actively commit suicide, for instance, they say, I've got a plan, I'm going to do it soon, and I live in the city of Madison, our 911 center is going to send the police, right? Because they have a plan, they have a way to do it, and they're actively saying that they're going to harm themselves. That's not a good CARES call. That's the police need to get there because that person needs to be possibly put in protective custody. But the 911 center makes those decisions, but they do get calls from 988.
Okay. Another question from Eric. Do they have the additional training to work with individuals with Alzheimer's and dementia?
Yeah, great question. So that is part of our community paramedic training, is we have gotten some dementia specific training. And you'll have to forgive me, I can't remember the name of the woman that came out and provided it. She provides a lot of training in Dane County and Madison. So I apologize, but yes, we did get a full day's worth of training. And then the crisis workers, that's part of their, that's part of their curriculum for their education and their history is to, understand how to deal with all levels of patients, from pediatric patients through the elderly and, and dealing with dementia. Now, I will certainly say that it's really hard to be the jack of all trades, right? It's hard because I've had a lot of questions about like, hey, do you have somebody that specifically works with kids? Or do you have somebody that specifically works with minorities? And it's hard for us to have specialty workers that are really good at working with one population of people. So they need to be the jack of all trades. But the important thing is recognizing the resource in the community. So if we were intersecting with someone in the community that was having a dementia-related behavioral health issue, what's important is the trauma-informed care that is given to that person, and then getting that person to the right professional in the community to help them further. And that's really the goal of our team, right? Is to not know 100% of every single patient's diagnosis, but understand where to refer that person to.
Good.
But yes, we did get some dementia training.
Good. Got another question from Paul. He says, I'm a Meals on Wheels volunteer. If I sense a client in crisis or distress, is 911 the best place to go?
It really is. If you think a CARES response is what's needed, 911 is the only way to get CARES. So, you can, as somebody that's coming across another human being that is in some sort of distress, right? Whether it's because of a medical problem, right? They're short of breath and they're having chest pain, or they're acting strangely. Maybe it's a blood sugar issue. You're basically just calling 911. And then the 911 center is going to ask you questions. And if the answers to those questions lead the 911 center to believe that it's a behavioral health emergency that's non-violent, they're going to send CARES. If what you're telling the 911 caller, or I'm sorry, the 911 call taker is that, hey, this person is acting really strange, like they're not speaking in complete sentences, it's all gibberish, they're probably going to send a medical response because we might be concerned that it's a stroke or a blood sugar issue. But then once our paramedics and firefighters get there and they can recognize that it's not a blood sugar issue, it's not a stroke, it's really a behavioral health problem, they can call CARES in. So all of our responders, whether it's police, fire, or EMS, has the ability to call CARES in once they recognize it's truly a CARES call. So it's really the job of the 911 center to decide what the right resource is. But to answer the question, if you come across someone that you think needs help and you don't know how else to provide them that help, call 911.
Another question, Jay, real quick here. Meredith asks, are there adequate trained support workers to do social work, case management, mental health workers? Perhaps you can explain a little more how you do tie into other services.
Yeah, so I will tell you, and this is anecdotally, that no, there's not enough service providers in our community, and it's hard to say that because Dane County is very resource rich, right? We do have a lot of good resources here, but I can tell you that not every patient is able to get referred to somebody because of the lack of beds or the lack of those resources, and so we do end up taking some people to the hospital because there is no other resource available in the community. We're hoping that within the next couple of years, the county is going to be able to build a behavioral health triage center, like a good brick and mortar 24/7 behavioral health triage center that will have a lot of these services available in our local area. The county exec Parisi has got money in the budget for that facility, and we know that'll help a lot. But yes, I will certainly say that there aren't enough resources for everybody that we come across.
And Larry also writes, he says, we live in an area that often needs help from CARES, but obviously not all situations happen during currently available hours. Will the hours expand anytime soon? And can we write letters to encourage funding?
Yeah, so any of your alders, your city alders or city council members, they're the ones that kind of decide about funding, and I can tell you we've had a lot of support from our city council and the mayor's office around this, and they're doing their best to fund it more. But So the answer is yes, you can certainly write letters, reach out to your alders. But our plan is, as of right now, is that we'll have the weekend hours available in a couple of months. And then what we really don't know right now is when we're going to be able to go 24/7. That's going to be a big expense because we're going to have to find more facilities to house people overnight. And it gets a little bit more complicated. The thing that I also worry about is the fact that this is only a city of Madison resource right now. And so if you're in Cottage Grove, Middleton, right, all of our surrounding communities in Dane County, this service isn't available to you. And so I would almost rather see services expand to the other communities around the city of Madison before we do something overnight, because there's just not as big of a need at 3 a.m. as there is during the day in communities around us. But that's all going to be funding driven. And it's us looking at data, right? It's us saying, hey, the need is much higher in this part of the county than it is in this other part. So we need to provide services here. We don't have a big need at 3 a.m. So maybe we provide 2 teams during the day and just 1 at night. There's a lot of different ways to format this service. And we're just trying to do it in a data-driven kind of, best practice way. But yes, it's a slow process. We have been getting a lot of feedback that we really need to expand more quickly. But that is unfortunately not the way that this system works. But yes, we're working on it.
Okay. And another question from Meredith, and if I don't put this quite right, Meredith, you jump in. It says, what about expanding the program that routinely includes a police officer, which I'm taking to mean these are the mental health officers?
Yeah. So there's quite a few programs around the country and in the state of Wisconsin that have what are called co-responder programs, where a social worker or a crisis worker responds with law enforcement. And in a lot of communities, that's the model that works for them because they don't have full-time firefighters and full-time EMS providers, right? So if you look in some of the smaller communities in Dane County, they have volunteer fire and volunteer EMS. So it's not reasonable to expect them to have a CARES type team. And so maybe for the Dane County sheriffs, maybe the Dane County Sheriff's Department works with a social worker and sends them with law enforcement. And that's a perfectly reasonable alternative. But the program that we decided, and when I say we, I mean, right, from the mayor's office to the Dane County Human Services and everybody else, we decided that the program we wanted in Madison was a non-law enforcement response. The police department already does a good job of responding to these to behavioral health calls when there's danger involved. But we want to take all of these calls that have no danger involved with them, no violence involved with them, and be able to send non-law enforcement people. So this particular model doesn't include law enforcement because we're trying to relieve the stress on law enforcement. And there are folks in the community that did not want to see a police officer walk through their door when they're having a behavioral health emergency. But both models are fine. It just depends on the community that you live in and the resources that you're able to provide. Cambridge would have a hard time having a CARES program because they don't have community paramedics. And so they would have to hire them separately. And so maybe it's better for them just to have somebody work with their law enforcement.
Mm-hmm. That's it for right now, Chig, go ahead.
Okay, so now I've just got some, we produced an annual report. So we were in service from September 1st of 2021. And at the end of September of 2022, we started putting together this annual report. So I'm just going to show you some stats. So the types of calls or the types of issues that patients were experiencing, you can see here, with the biggest grouping being at 17% of suicidal or homicidal thoughts. And then it goes down to agitation, alcohol use, anxiety, depression, and then other behavioral health concerns, is at 23%. Those are just things that didn't fit neatly into these other categories. And so again, please speak up if you have any questions about any of this data that I'm showing.
Homicidal thoughts, that would not seem to be a CARES call. I mean, how do you deal with something like that? How do you know that, I guess I'm going to try and kill anybody?
Yeah, so if somebody's thinking about hurting themselves or thinking about hurting someone else, but they don't have a plan, they don't have any specifics around it, they're just having these troublesome thoughts, then that's a CARES response. If somebody says, I want to kill somebody right now, and I've got a plan and a weapon, that's a police response. So it's just really the 911 dispatcher talking to the person and figuring out whether it's a truly imminent, dangerous situation or whether or not this person is just having troubling thoughts.
What kind of training would the 911 team get? Because trying to distinguish between these subtleties would seem to be really difficult.
It is, and this is what the 911 call takers and dispatchers have been doing for decades. But previously, they only had three main resources: police, EMS, and fire. Now they've got this extra resource of the CARES team. So they always use a protocol of questions. They've got basically these cards in front of them that tell them which questions to ask. And so that's how they get to where they need to get with figuring out which response to send. But they do take the crisis intervention partner training, the CIP training. So they do have some training in this area, but they've been dealing with these types of calls for a very long time. They just haven't had CARES available to them. Anytime a paramedic goes on a medical call, the 911 center is also asking some safety questions, right? Because we don't want to send a paramedic into a shortness of breath call if that person that's short of breath is saying they want to kill everybody, right? So they always have to ask safety questions anyway to determine whether or not they're going to send the police. So there is mental health training for the dispatchers, but it's not only because of CARES. It's just because that's the nature of the work they do.
Okay, great.
So this is kind of some of the challenges that people report around their behavioral health emergencies, the biggest being housing insecurity and substance use.
If you look through the sheriff's booking log, who's at the jail, enormous number of people are at the jail for alcohol abuse, drug abuse, selling drugs, whatever. Yeah, how do you plug into work with that type of a problem?
Yeah, it's complicated. There's a couple of programs. One is the MARI program, the Madison Area Recovery Initiative, I believe it is. And then there's this Pathways to Recovery, which is a grant that the police department got to help people get diverted from jail and get put into treatment for first-time offenders. So there's programs out there that the CARES team can help people get connected to. So if you're having a substance use issue and you're voluntary, in other words, you're saying, hey, I want help, CARES can connect you with the right program. The problem is with a lot of people that have substance use issues is that they don't voluntarily want help, right? So they might end up doing things that are illegal, so they end up in the jail system, or they're not being compliant, so they end up in the jail system. And CARES can't put anybody in protective custody. CARES can only help people that voluntarily are asking for help. So we can take people to detox because there are quite a few people that say, hey, I'm done drinking. I hate it and I really want to go to detox. CARES can do that for them. But we can't say you're going to detox against your will and put them in protective custody. That's when we have to call the police department in.
What percentage of your calls would you say end up like that? Can't deal with these guys, I'm calling the police.
I've got a graph that'll show that in a little bit because there are quite a few people that we go see that don't want to see us.
Yep. Okay.
Yeah, I'll get to that for you. So this is kind of CARES patients that have pre-existing connections with other services. So we always like to know if somebody's connected somewhere so that we can reconnect them with services. So Journey Mental Health is the biggest one. And so it's really nice for us to have a Journey Mental Health crisis worker be able to come into somebody's home with their laptop and be able to access that person's care plan, right? So they can see what the history is, they can see what the best path forward is. When a police officer or a firefighter paramedic walks in and sits down with somebody, we have no idea what their history is. We can only go off of what they tell us, but having access to the person's records is certainly beneficial. And then you can see all the other services that people have been previously connected with before they saw us. Of course, we gather as much demographic information as possible. This is just one slide, but we gather, veteran status, insurance status, sexual orientation, language, everything we can. So this is just an example. This is just our racial and ethnic backgrounds. You can look at this and say, boy, we're really overserving the white community, but just remember that the Madison census has these are similar numbers to the folks that live in the Madison area. There's about 7% Black or African American in the Madison area, 70% white or Caucasian. I would say that we're probably underserving the Latino and Asian populations a little bit, and there's a lot of layers as to why that is. I can tell you that this is just my personal experience, that a lot of folks in the Asian community, they're a lot more stoic, and they just do not call 911 until they really need it, right? And so we don't see as many of our Asian community members as there are really, and it's hard to put your finger on exactly why that is. We want to serve everybody equally, but there are just some groups of people that do not want to call 911 until people are actually dying. And so that's just an interesting side note, but just want to make sure everybody understands that we do collect as much demographic information as possible. So just to kind of show you on a table what our expansion has looked like, like I said, in September 1st of 2021, we started out with that one team, 11 a.m. to 7 p.m. in the Central District. December 22nd of 2021, we started responding citywide. April 20th of 2022, so this last year, we added that second team part-time because we were trying to build staff up. And then July 25th, we were able to have two teams full-time, Monday through Friday, 8 a.m. to 8 p.m. And so this is just a kind of a timeline of how the call volume increased since we started September of 2021 through August of 2022. As we expanded, we certainly got more busy, right? You put more people on the streets to respond, and we're going to be able to handle more calls. And so I'm sorry, I just want to go back real quick. So this first graph is a total number of calls, and then this is the number of calls per day that the team is in service. And like I mentioned earlier, we do quite a few check welfare calls. So about 19% of the calls that they go on are to check welfare or check person. So among the patients that CARES has made contact with on the check welfare responses, 54% of those people needed or presented with some sort of behavioral health concern. So they needed some sort of behavioral health intervention. So that's the reason why we go on check welfare calls, because over half of them actually are a behavioral health emergency. And when you look at the other programs around the country, the CAHOOTS model in Eugene, Oregon, the STAR program in Denver, about 20 to 25% of the calls they go on is check welfare as well. So that's why when people say, well, why is CARES just going to check on my grandma because we haven't heard from her? This is the reason, because people tend to have behavioral health issues when they're not in contact with other folks as they normally are. And so the impact of CARES, so some more stats for you. So we addressed most people's needs in person without having to transport them somewhere. So you can see this 12% on top here, patient decline any help from CARES. So that's what I was talking about earlier, Mike, was there's times where a citizen calls 911 for another citizen because they think that other citizen needs help. But when we get there, that other citizen is saying, nope, I don't want to talk to you. I don't want anything to do with this. And so we can't force ourselves on people. So we've also 13% of the calls have just been by phone only. There are quite a few people that actually don't want somebody coming into their home in person. They want to talk with somebody on the phone, and they want to get resources over the phone or get whatever help it is that they want only over the phone because they don't like anybody visiting them. 38% has been CARES provided in-person help, but didn't need to be transported anywhere. 31% is CARES provided in-person help and then transported them somewhere in the community. And then these bottom two numbers are important ones. The CARES transferred the patient to another EMS agency. So in other words, CARES got there first And the paramedic on the CARES team recognized that this was actually a medical problem. And so they had to call an ambulance in. And then the last one here, to me, is the most important number, is that we've only had to transfer 3% of our calls to a police officer. So 100% of these calls before CARES was here, 100% of them would have gone to law enforcement, right? Or almost 100%. Now only 3% of them are ending up with some sort of law enforcement intervention. And these calls, this 3% tends to be because the person needs to be put in protective custody to protect themselves from harming themselves. We've only had 2 actual arrests. So as of today, CARES has gone on over 1,650 responses, and 2 of them have ended up in somebody being actually arrested. Jim,
I have a question.
Yep.
Excuse me, Jay, I've got a question, Jim Jenkins. How do you transport people? Just physically, how do you protect your CARES people from any possible danger inside the vehicle and so on?
Yep, great question. So initially, when we very first started, we had a minivan that had no lights and sirens. It was just a minivan with a little CARES logo on it. And the reason we started with a minivan was because we were told by members of the community that they didn't want emergency vehicles racing into the home. They didn't want people in uniform. So we put our folks in civilian clothes. They had their credentials around their neck so people could identify them. But when we were using the minivan in the central district only, it was okay because they didn't have to go very far. They didn't, they could get to people relatively quickly. But as soon as we started responding citywide, the minivan couldn't get to people in time, right? It was taking too long for us to get from downtown to the far west side. So we transitioned to fire department Ford Explorers that have lights and sirens. So that's what we're using currently, is a Ford Explorer with lights and sirens. And they have there's a plexiglass partition between the back seat and the front seat. And we've had a couple of people that have gotten escalated during transport and have tried to open the door, right? But because it's a police Ford Interceptor, that we have automatic locks and automatic window locks. So unfortunately, the back seat probably does feel a little bit like a police car. Even though it's branded with fire department stuff and it has emergency lights, it might feel a little bit like a police car, but that's for our safety. So yeah, so we're using, but people tend to be, so far people tend to be okay with us pulling up to their home in a fire department vehicle. But what we do tell our paramedics is, hey, please turn the lights and sirens off like way down the block, because that's very escalating for people, right? If you're sitting at home having a behavioral health emergency and there's sirens pulling up into your driveway, that's going to make things worse. So we try to make them be very thoughtful about lights and sirens use.
Yeah, thank you.
Yep. And how are we doing on time? Oh, we're good. We got like 15 minutes. Okay, excellent. Just want to make sure. Here's something that is still a little frustrating for me. 31% of the CARES patients that we transport to other services, 18% of those 31% are still going to emergency rooms. What that tells me is what we were saying earlier. There aren't enough services available in the city for us to not have to use emergency rooms at all. So we're still using emergency rooms, but previously we were using the emergency rooms much, much more. Like a police officer. Yeah, go ahead, Jim.
Yeah, another question there. ERs are just jammed full of people. The wait is for hours long often. Do your CARES people remain with the patient that whole time?
Yeah, so luckily what we've worked out with the local hospitals is that we are able to get in and get the patient handed off to a social worker at the hospital. We never leave without making contact with a provider. So they might not get into an emergency room right away, but we make contact with a triage nurse who is able to get a hold of a social worker or some behavioral health provider that can then be with a patient. Because the last thing we want to do is walk a person into triage and have them sit there for 3 hours, because that's not going to do good for them. So yes, we always make sure we provide some sort of handoff to a provider. But they can't expect us to sit there for 2 hours either, because then that's not benefiting the citizens. But yeah, so we have a system worked out with the hospitals. But still, taking people to the hospitals is our last resort, right? That's the last thing we want to have to do. It's just unfortunate until that triage center that I was talking about earlier is built in Dane County. We really don't have another option for some people. So we're still working on a lot of that. So 24% of the CARES patients were referred to one or more services in the community. Crisis lines were the most common, with 12% of all CARES patients being referred to crisis lines. And like I mentioned to you, some people just want to talk to somebody on the phone, right? They actually say, don't knock on my door because I won't answer it, but I need to talk to somebody. So of the people that do get referred, so this isn't just transported, this is any referral. This is where the referrals go. So CARES responds to 57% of the estimated number of mental health related calls for service in the time that we're in service. So Monday through Friday, 8 a.m. to 8 p.m., we're only able to respond to 57% of the calls because we're on calls. So there still are calls that happen during the day where police need to go. Right. So if you call and say, hey, I want CARES here, the 911 center might say to you, well, CARES is busy right now, so we're going to send law enforcement instead. And some people say, you know what, I just want to wait for CARES. And so we can have people that actually don't mind waiting 20 minutes or a half an hour in order for CARES to get there. But that's up to the caller. Sometimes they just send police because they have to. So this tells us that we need more teams during the day, right?
Jay Meredith asked, do your patients get priority service when they get to the emergency room?
Well, they get priority service from a behavioral health professional, but they're not getting priority service from the ER doc, right? The ER doctors and ER nurses, they need to provide service based on their triage system for what's life-threatening. But what we do have is that we can talk to the triage nurse about getting in contact with the social worker or some other behavioral health professional. And our CARES team won't just leave that person alone. So priority help, yes, but not priority as far as getting to see an ER doc, if that makes sense. So some key takeaways from that first year, right? So this is just September 1 through, through the end of August of 2022, but CARES responded to 935 calls. As I mentioned a little bit ago, as of today, we've responded to over 1,600. Each response averaging about an hour. So from the time that the team is called until they're done with the call, it takes them about an hour. So, they're long calls. We made contact with 724 individuals among the 935 calls for service. We have repeat callers. CARES responded to 50, well, I just mentioned this one on the last slide, but we responded to 57% of the total number of calls and 9% of the daily average check welfare calls that occurred in Madison. So the police do still go on some check welfare calls. And like I mentioned, only 3% of our patients had to be transferred to police, which is a good number for us. We've had very little law enforcement involvement in our CARES calls. And then the last one, CARES teams only transported 18% of the 724 patients that made contact with to emergency rooms. So again, we're still using emergency rooms, but a lot less than we previously did. So these are kind of the big things for us that tell us whether we're kind of succeeding or not succeeding in what we're doing. And then I think I mentioned at the end of this first quarter, or hopefully by March, April timeframe, we'll have another team on the weekends so that we can cover 8 a.m. to 8 p.m. during the weekends, with one team working 8 to 5, another team working 11 to 8. And then October of this year, we got approved for another community paramedic and another crisis worker so that we can put a third team on the streets during the day, during the week. Remember, I said we're missing 57% of those calls during the day, during the week. So we're going to be able to put a third team on the streets to hopefully capture more of those 57%. And that'll happen in the fourth quarter of 2023.
So Meredith is asking, how many CARES teams do you aim for to serve the Madison community? Do you have an estimate of what you think is necessary?
Boy, that has been a common question, and we haven't put our finger on it specifically because we think that we're going to probably end up expanding out into the county a little bit, maybe before we do 24/7. We're not sure about that, but I would say that, and it also depends on the hours of the day that they work, but I would say that in order for us to cover 24 hours a day, 7 days a week, we would need at least 8 community paramedics and 8 crisis workers so that they could form teams that could cover at least 4 teams during that 24-hour period. And that's, because we have to worry about vacations and sick days and everything else. So you have to have backup employees. And so it's an expensive venture. I can tell you right now that we're about $1.2 million with our current setup annually. And that includes salaries, benefits, vehicles, equipment, and everything that it takes to run this team, supervision, everything else. So in order to run 24/7, it's going to be a couple $2 million a year venture.
Tess also asked, do you have any data on what percentage of calls involve individuals with dementia or cognitive impairment?
We do. Let me take 1 second to do something real quick. We have a data dashboard, and if I can just bring that up, I can bring up some more specifics about the actual diagnosis. So this data dashboard is internal facing. In other words, we don't share this with the community as an actual link, but I'm happy to show you, let's see, incident and medical. Here's what I want. So this date range is from September 2nd, 2021 to November 30th of 2022. So this is old data back to November. But the primary impression category here is what the paramedics impression is. So that's them saying, hey, this person was agitated, they had alcohol use, altered mental status, right? As you go through these are all the paramedic impressions. And the primary complaint is what the person is saying. So the patient themselves making a complaint of agitation, intoxication, altered mental status, anxiety, behavioral health, chronic pain, depression, hallucinations, homelessness, on down. This primary diagnosis is what's provided by Journey Mental Health. So this is 63%, it just says mental health, 1% neurocognitive, 22% serious and persistent mental illness, 6% substance use disorder, 7% not reported. Co-occurring substance use is up here, insured status. So it doesn't really drill down into, I'm just trying to see. I don't think there's going to be a dementia specific, because dementia would fall into these other categories. I'm just looking further and to make sure that I'm not incorrect. But it would fall, dementia would most commonly fall under altered mental status or some other general category. Because paramedics don't diagnose, right? So we don't diagnose somebody with Alzheimer's. That would come from the Journey record. I'm sorry, I didn't answer that question very well, but I can show you some other, since we've got a few minutes left here, kind of show you some of the other data that we collect. So this is kind of our call volume over time, previously served by Journey, previously served by CARES. This is all the demographic information I was talking about. And this is kind of, some of the age stuff is pertinent, right? We don't see a lot of people under 17, and about 20% of the people we see are over 65. So we do intersect with the older populations quite frequently. But race, ethnicity, like I mentioned before, sex, gender identity, the language of service, veteran status, and experiencing homelessness. About 13% of the folks that we see are experiencing homelessness. Jim, go ahead.
Yeah, 20% at 65 and older would imply that there is a dementia element to this. What are you seeing those people for?
I can't break out just the 65 alone. And I also just want to state, all of these age ranges are pretty short time periods. So, 18 to 24 is 6 years, 25, right? So these are shorter time periods. 65 plus covers 65 up to 100, right? Over 100. So there's a lot more age ranges in that 65 plus. So I think that's why it shows a large percentage. But I agree with you. If we're seeing people that are over 65, I have to imagine that a good percentage of them, are dealing with some level of dementia, right?
Yeah,
That makes sense. We just don't as crisis responders, we're not always aware of that exact diagnosis unless a family member tells us, or unless Journey sees it in a record.
Yeah.
We had a question, Jay, from Meredith. She says, how many teams do Cahoots or STARS have to serve in their communities? What's the cost savings to the community? Could you compare this maybe to other communities that are trying to develop these programs?
Yeah, you know, we've run some cost analysis, and it's really hard to understand about the financials of all of this work, right? Like there's one side that tells people, hey, if the fire department isn't transporting these people in an ambulance, then you're not recouping, we're not generating any revenue, right? We're not charging for this service. So then you say, well, you're taking operational stress off the police department, so they're not as busy with these non-law enforcement type calls. So maybe you're cutting down on some of their overtime. But this program costs us a lot, but I don't like to think about it like I'm not running a business here, right? Like I'm a civil servant, I'm a first responder. I think about this in terms of people in the community are getting a much better service than they were previously. So I don't, and I'm not a data-driven person, so I don't think about the cost stuff a lot. But from the Cahoots program, it's in Eugene, Oregon. That's a smaller area. They have more people and they run 24/7, but they're not fire department based either. They're more of a kind of, they get a lot more private funding, and they work with a clinic there, the Whitebird Clinic. The STAR program in Denver and San Francisco actually has a street crisis response team too that has started relatively recently that just works in the Tenderloin district, and they've got like 6 or 8 teams just working in the Tenderloin district, you know, because they're much bigger than we are. So I'm not the right person, I guess, to compare like financials between programs, but we do study other programs a lot because we want to know what is best practice. But yeah, I'm not able to speak on the money very well. And I know we're coming up against 11 o'clock. I'm happy to stay on. I don't have another meeting or anything right now. I understand if people need to get off, but you know, I'll stay here as long as it takes to answer all your questions. So.
Jay, is there potential need for volunteers going forward?
So that's another thing that's been brought up, and we really have a hard time understanding how we would integrate volunteers. And the big thing about this is peer support. You know, peer support is really a best practice out there. And having a peer support person on the team, they do that in San Francisco. They have a 3-person team. They have a peer support specialist, a crisis worker, and a paramedic. And we haven't really figured out how we can integrate peer support into our response. We use peer support after the fact, right? Because if we see somebody that could benefit from somebody that has lived experience in regard to addiction, we'll hook them up with peer support after the fact, but we don't have any capacity to put a volunteer in the vehicle, right? Because then we have to worry about liability and insurance and HIPAA and all of these other things, right? So we can't just take volunteers with us. And it's hard for us to say, to go on a call for a behavioral health emergency and refer somebody to a volunteer, right? Because we have to have, you know, all of these very carefully laid out HIPAA business agreements, and we have to be careful who we share information with. So volunteerism would be great to use, but there's not a great mechanism.
But what I was thinking more, you know, when you talked about what other communities are doing, a volunteer could launch a program to contact communities all over the country and find out, just, you know, compare.
Oh, sure.
You know, that kind of thing, more administrative or background kind of stuff.
Yeah, I agree with you. I could see how that could be beneficial, for sure. And Margie, did you have a question? I'm sorry.
Well, I just kind of wanted to make a comment too. When it is hard to figure out what the true value is in terms of financial information for this program. But one thing I must say is that the value of a team coming in that they don't, you know, police, when they come, they have to bring weapons. That's part of their mission. Mm-hmm. So you have a team that's coming in that doesn't have weapons, that can maybe ensure that the situation doesn't escalate. And that sort of thing is immeasurable, really. I mean,
I got to second that. This program is so valuable, I think, to the community. and you just can't count that. I mean, it's hard to, you can't cost it, but
Yeah,
thumbs up.
agreed. You know,
Yeah.
and we can sit here and say that anecdotally, we know we're saving the insurance companies a lot of money, right? We're saving the hospitals money because they're not being flooded with people that don't need to be there and maybe can't pay. So, you know, I think there's a lot of there's a lot of segments of the community that we work with that are saving money, right? And that's why we think hospitals and insurance companies should be giving us money to provide the service we're providing. But we're working on that too.
I just want to say thanks personally for what you guys are doing and your people are doing, and hope you're able to grow as much as we need.
Yeah, thank you. We've gotten nothing but really positive feedback and really good support. You know, the city of Madison unfortunately doesn't have a you know, an endless budget. You know, and the pandemic has stressed us a lot. I wish we had more resources to pour towards this and expand more quickly, but we're doing our best, and we'll get there.